Hello, everyone. Welcome to today's webinar, Addressing Alzheimer's Across the Whole Public Health Agency. Thank you so much for joining us today. We hope it's going to be an informative time for you. My name is Shean. I'm the Associate Director of Public Health for the Alzheimer's Association, and I'm joined today by my colleague, Molly French, the Director of Public Health here in our Washington, D.C. Public Policy Office. Today's webinar is designed to introduce and explain an innovative approach that the Washington State Department of Health is taking to ensure that each facet of the agency is working and helping to address brain health, Alzheimer's, and other dementias. Today's webinar will also feature new data about the intersection of chronic conditions and cognitive decline, and to start off, we're going to examine a life course approach to Alzheimer's and other dementias. But just a few housekeeping items before we get started. Please know that, as you heard right at the top of the hour, we are recording today's webinar, so it'll be available to others who couldn't join the call today. And in the coming days, we'll make sure to email all registrants a copy of the slide deck, a link to the recording, as well as any links featured in today's webinar. All phone lines have been placed on mute, but please, we really encourage Q&A. We really encourage interaction throughout the entire presentation. So we will be taking questions and having a question and answer session at the end of today's presentation. Please use the Q&A feature that you'll find either on the right-hand side of your screen or maybe at the top. If you don't see that little feature, just say Q&A, wiggle your mouse around, and the drop-down should show up. But please use that Q&A feature throughout today's presentation if you have a question, if you have a comment, and we'll compile them at the end of today's webinar. Before we get started, we would like to acknowledge the CDC, the Centers for Disease Control and Prevention, for the cooperative agreement that enables to offer this webinar today. But please do know that the opinions expressed during the webinar are solely those of the speakers. Speaking of speakers, we have a great set of them for you today. In addition to the wonderful speakers that you'll hear from the Washington State Department of Health and the CDC, whom I'll introduce momentarily, we'll hear from ASTO, the Association of State and Territorial Health Officials, who will provide some context and translation to all those listening to help translate and take the next step. Before we get started, I think it's helpful to really think about Alzheimer's and dementia from a life course perspective. More and more research is showing that Alzheimer's has a long etiology, that changes in the brain, you might have heard of amyloid, you might have heard of tau protein. These are commonly called plaques and tangles. Changes like those can happen in the brain years before, sometimes even decades before symptoms appear that are related to dementia. And so we know that this long etiology provides many opportunities for intervention across the lifespan. And indeed, we know that Alzheimer's is not just an aging issue. Research is showing that certain healthy behaviors at any age can help reduce the risk of future cognitive decline. These are the same healthy behaviors that public health is intimately familiar with: quitting smoking, being physically active, managing heart health. These are the kinds of behaviors that can and should be encouraged and promoted across the lifespan. They help keep us not only physically healthy, but they can help protect our cognition in later life. But additionally, Alzheimer's is not just an aging issue for those affected by dementia. Currently, nearly 200,000 individuals in America live with Alzheimer's under the age of 65. And as we all know, caregivers for those people living with dementia can be any age. So truly, Alzheimer's is not just an aging issue, it has a huge public health component. This public health perspective is helpful when thinking about how public health can intervene. Hopefully we have quite a few folks from the public health arena on the phone today, and thinking about Alzheimer's through this life course perspective can provide us many opportunities for intervention. So what you see on your screen is the dementia continuum in that purple semicircle. It starts with healthy cognitive functioning and progresses through cognitive impairment before reaching the dementia stage. So of someone who will go on to develop dementia, this is what their cognitive life cycle looks like. Healthy cognitive functioning progressing through to the dementia stage. But I want to focus your attention on those outer three rings in blue, because these are the ways that public health can intervene throughout the dementia continuum. At the beginning, we know that public health can promote those healthy behaviors I just mentioned to reduce the risk of cognitive decline. But these can go beyond just those healthy behaviors that I mentioned. This could be encouraging teenagers to wear helmets, for instance, to protect their brain from traumatic brain injury. It could be getting middle-aged Americans to exercise weekly. It could be managing heart conditions, making sure that hypertension is well managed, or reducing your risk for stroke. Public health can then go on and encourage early detection and diagnosis of cognitive impairment and dementia. We can do these things by running a public awareness campaign. We can train healthcare providers about validated assessment tools to make sure that those individuals who are experiencing cognitive complaints get in early and have care consultations with their healthcare providers. So we see that in that outer blue ring there. And then towards the right-hand side of the dementia continuum, we know that public health can ensure the safety of those with memory issues and improve the quality of care for people impacted by dementia in their communities. We can do this by setting training standards, by ensuring quality measures, and helping meet the needs of caregivers. By using this life course approach, public health has numerous opportunities to alter the trajectory of Alzheimer's and improve brain health along the way. And this perspective, this framing, is very helpful for what we're going to discuss and what you're going to hear from our speakers in just a minute. And as we go and hear from those speakers, one tool I want you to keep in mind is the Healthy Brain Initiative. This is the broader public health field can take steps to address dementia by using the Healthy Brain Initiative, and specifically the Healthy Brain Initiative Roadmap Series. What you see on your screen is the Healthy Brain Initiative Roadmap Series, the HBI Roadmap. Right in the middle of the screen, in the larger size, is the Healthy Brain Initiative Roadmap 2018 to 2023, as well as the Roadmap for Indian Country, are two current roadmaps that are out in the public health field. But in case you don't know, the Healthy Brain Initiative is a public-private collaboration designed to advance cognitive health as an integral component of public health. It's housed at the CDC within the Alzheimer's Disease and Healthy Aging Program. And the Roadmap Series is designed to offer that practical, expert-guided actions that state, local, and tribal public health leaders can take to address Alzheimer's in their communities, help reduce the risk of cognitive decline, and meet the needs of caregivers. So on your screen, as I said, we have the third iteration of the HBI roadmap that's designed specifically for state and local public health leaders, as well as the roadmap for Indian Country, which is the first ever guide designed to start conversations about dementia in the American Indian and Alaska Native community. And before I turn it over to our speakers, one helpful context to know is how the HBI roadmap is organized. The HBI roadmap embraces that life course perspective that I just mentioned and encourages the entire public health field to consider their unique roles and how they can use those roles to mitigate the future impact of Alzheimer's. It's organized by 4 essential services of public health to help aid public health leaders in identifying opportunities that align existing services, develop new programs, and help institute policy, system, and environmental changes that address Alzheimer's in their jurisdictions. This framework may help those in public health divisions and departments that may not otherwise see a role for themselves in dementia find one and recognize how their specific area can address brain health. And before I turn it over to our wonderful speakers, I want to highlight one particular structural feature that may be a little bit difficult to see on your screen, but it's in the upper right-hand corner, that outer blue ring, which you see it's the 4 essential services are surrounded by 3 overarching themes. And in the upper right, you see collaborate across multiple sectors. So the actions of the HBI roadmap that we are going to discuss were drafted with this overarching theme in mind. Collaboration is truly at the heart of the roadmap. It's necessary to be effective, and it's one of the reasons that it's an effective public health tool. So I'm very excited to turn it over to our speakers who are going to explore this idea of collaboration and walk us through what a whole agency approach to brain health and Alzheimer's can look like. I'm very pleased to welcome Janna Bardi and Marci Getz from the Washington State Department of Health today. And before I turn it over, let me give a short bio so you know just how experienced and expertized these speakers are. Janna Bardi is the Chief of Public Health Practice at the Washington State Department of Health. She assumed this role in 2018 to bring new focus to evidence-based public health practice of the agency and also work on agency-wide efforts including healthy families and aging. She's been with the agency for 25 years and held positions including Assistant Secretary for Prevention and Community Health Division, State Immunization Director, State Maternal and Child Health Director, and State Chronic Disease Director. She has a Master of Public Health and Behavioral Science and Health Education from UCLA. Marci Getz has served as Director of Healthy Aging since 2018, and she provides leadership, strategic planning, and coordination and consultation to advance the work of healthy aging, Alzheimer's disease, and other dementias at the state, local, and national level. She addresses health disparities to promote healthy aging across the lifespan and is a member of the Washington State Dementia Action Collaborative. Thank you so much, Jan and Marci. I'll turn it over to you.
Thank you, John. It is a pleasure to be with you all today, and thanks so much for providing us this opportunity to share our work with you. Here's what we're planning to cover today. Although we had some programs in some parts of our organization already using an aging perspective, and maybe also incorporating dementia and caregiver perspectives, we weren't systematically incorporating these perspectives into all parts of our agency where it made sense to do so. You can advance the slide.
Seems to be a bit of a hesitation in the slides, so.
Okay, I'll keep going in hopes that the slides catch up. So the aim of our assessment was to systematically integrate aging and the Healthy Brain Initiative objectives into our agency work. And go ahead and go to slide 3 now for us. The Washington State Department of Health employs about 1,850 people and has offices in 5 cities across the state. We were aware that our agency was involved in some great work supporting healthy aging, but no one could easily identify all the ways healthy aging, Alzheimer's, or other dementias were being addressed by the whole agency. And this was problematic for a few reasons. It prevented us from creating opportunities to collaborate within our organization due to the lack of knowledge and awareness about what others were doing. It prevented us from creating opportunities with our sister state agencies and community-based organizations, and it made it difficult to know where to begin attempting to implement the Healthy Brain Initiative roadmap, the 25 actions for public health. So we knew that we needed to begin by making the case with our agency leadership that healthy aging, including addressing Alzheimer's disease and other dementias, needed to be a focus of our public health work. Until recently, the work of addressing Alzheimer's disease and other dementias was primarily done by our Aging and Long-Term Care Support Administration, which is within a different state agency, the Department of Social and Health Services. So we created this document that you see on your screen. It's a 2-sided document that provides the definition of healthy aging, which you can see on the left in the blue, and that definition is from Trust for America's Health. The document also provided state and national data, frameworks, our proposal, who our partners are, and some other resources. The call to action was that we asked our agency leadership team for their support to create a short-term DOH Healthy Aging work group, and we asked each of them to decide who should be invited to participate in that work group. This work group is how we implemented our assessment. Next slide, please. Although some areas of our agency, like the chronic disease prevention programs, are very familiar with life course theory and a healthy aging approach to work, other areas are not very familiar and have not integrated it into their work. By using life course theory and this definition of healthy aging in our assessment, we broaden the base of our agency staff who are comfortable with it. The definition of healthy aging is on the next slide, but I'll read it since the slides seem to be delayed a bit. Healthy aging is maximizing physical, mental, and social well-being while recognizing that aging is often accompanied by chronic illness and functional limitations. Efforts include promoting health, preventing physical, cognitive, and mental health, and facilitating social engagement. For staff who were less familiar with life course theory and this definition, it seemed like this was an easier way to begin our assessment. Every staff member was able to describe how their work fit a healthy aging definition, while very few were already able to describe addressing dementia, Alzheimer's, or support for caregivers. Next slide, please. With the foundation of life course theory and healthy aging laid, we supported the work group to consider the Healthy Brain Initiative. The Healthy Brain Initiative objectives are efforts that public health and partners can take to anticipate and respond to the growing impact of Alzheimer's disease and other dementias on every facet of society, with the aims of promoting cognitive health, addressing cognitive impairment for people living in community, and helping meet the needs of caregivers. And I'm ready for the next slide again, and we've got a delay going here, so it should be slide 15 right now.
Yeah, I'm showing slide 15 on our screen. Hopefully others are seeing that as well. So let's go ahead and proceed as we were. Great,
okay,
thank you.
Thanks, Don. The Healthy Brain Initiative Roadmap 2018 to 2023, and specifically the 25 action items for public health, have provided us a framework and action items rooted in public health approach for addressing health issues. They encompass CDC's 10 essential public health services. The 25 action items are organized in the 4 areas that John had described: educate and empower, monitor and evaluate, develop policies and mobilize partnerships, and ensure a competent workforce. As we move forward in our presentation, Marci will help you see how we've used this framework and the action items with our Healthy Aging work group for our assessment. So with that, I will turn it over to Marci Getz.
Thank you so much, Janna, and thank you so much to all of you who are participating today on the call. And John, if we'll be on slide 17 now, and I'm going to go ahead and start. So as Janna said, we organized and developed a work group here at Department of Health, and oftentimes we'll call it DOH. And we made sure that we had, when we asked for this work group participation, that we had clearly identified goals of this short-term work group. I think anyone on the phone could say that they've been a part of a work group where there wasn't a clear goal or objective. We wanted to make sure that. And the work of the group was to clearly identify, sorry, the slides are throwing me off a little bit, but so the work group is to conduct an internal assessment of touch points regarding aging work within Department of Health, and to provide an opportunity to get to know the work of colleagues around the agency and identify areas of opportunity to leverage existing work. We made sure each meeting created an opportunity to get to know one another, the work folks are doing, and to move our assessment process along. Each meeting had a pre-meeting assignment. We recognize participants are coming with a variety of backgrounds and knowledge regarding these aging topics. This can be very positive, as people are excited to learn new information and challenge themselves to make connections to their current body of work. But this can also be challenging, as those coming to the table with lots of knowledge and experience can become frustrated with the assessment process, and you have to manage expectations. Next slide, please. So the assessment we used, and John did a great job of queuing this up, was using the life course perspective, which he talked about. And then Janna talked about how we use the Healthy Brain Initiative roadmap. And I want to say to folks on the call, if you haven't gotten a chance to look at it, it would be a wonderful thing to look through. And also they have an executive summary that we have used in all our work that identifies 25 actions for state and local public health agencies and their partners to accomplish. And they're in 4 areas that we've already talked about: educate and empower, develop policies and mobilize partnerships, assure a competent workforce, and monitor and evaluate. So our work group members identified work that they were doing that supports healthy aging. For example, immunizations. That supports healthy aging through the lifespan. Tobacco cessation, diabetes prevention and management. And then they were asked to evaluate if any of the work they identified would qualify for any of the 25 Healthy Brain Initiative action items that are part of the executive summary and if they didn't qualify to be one of those 25 action items and those objectives, was there an opportunity to make any changes that would help them qualify? And one thing that we used a lot was a brochure that was by the National Alzheimer's Association. And if you Google 10 Ways to Love Your Brain, it's a wonderful brochure that lists things that we're already doing in chronic disease prevention, like moving your body, eating well, those type of things. So we also use that as well. Next slide, please. So the opportunities, so far we have identified approximately, and we're still in our assessment process, I should say, 86 new opportunities to include the Healthy Brain Initiative objectives and action items into our current body of work. And some of the examples are things that we've framed our examples in 3 different areas. One is things that we kind of expected would come out, things that we thought were less likely, and then really unexpected areas. So I'm just going to give you a few examples. And that is, like, we adjusted tobacco prevention messaging, or we're going to incorporate the benefits of tobacco cessation to brain health. Adjust diet, nutrition, and exercise messaging to add information about brain health and increase awareness about the benefits of social engagement possible through supplemental nutrition assistance program, for example, Meals on Wheels. That's not just nutrition, it's social connection. Some that fell from the less likely areas were infectious disease prevention programs. They are integrating messages about brain health into annual flu vaccination letters that go to long-term care facilities and on the For Seniors portion of our department website. Rural workforce recruitment, retention, and job development for home care aides. Increase attention to job roles that support dementia care, and use programs like Project ECHO telehealth to support providers in doing cognitive decline assessment. Some of our really unexpected areas were with our health facilities licensing. So with facilities licensure, application process that we use is for hospitals and behavioral health and residential treatment facilities to engage applicants in planning efforts to establish services, policies that are supportive for people with dementia and their caregivers, and that emergency preparedness response plans include addressing the special needs of people with dementia and their caregivers. And one other thing I wanted to add about this is that once we did this assessment and we're looking at the opportunities that we have to work on things, we will have covered 23 of the 25 objective areas within the Healthy Brain Initiative 25 action items. And then many of the objectives, we have a variety of different activities under those. Next slide, please. So what are our next steps? We need to complete our assessment. And so part of that will be working through with the staff that we have, our work group members, there's 31 of us, and working through with people of the opportunities they've identified. Do any of them need additional resources? What kind of supports could we provide to them? So we have to complete our assessment, and then we're going to create some sort of diagram depicting the work identified in the assessment. And hopefully the diagram will show the work through our organizational structures per division from a life course perspective, and using the HBI framework, identifying what we're already doing and where are our opportunities. And then we're going to present this diagram and the findings back to our agency leadership team. And we'll use the assessment to create a work plan to support implementing the HBI opportunities identified. And when I say HBI, I mean Healthy Brain Initiative. And I want to note that the opportunities that people came up with, many of them can be implemented without additional funds. But I do want to say that Janna and I's position has been key, and those positions have been funded. through both state funding, through the Dementia Action Collaborative. You need to have staffing time to actually organize all this, implement it, bring people together. So that is an important step. Next slide, please. So through a past grant that the Department of Health received from ASTO and the National Alzheimer's Association, we were fortunate enough to work with our partners at the Center for Multicultural Health in Seattle. And this picture that will hopefully show up on your screen is of a hand fan. And we worked together to do some outreach at African American churches in the greater Seattle area and put messages on these fans that were addressing traditional public health messages such as exercise, smoking, diabetes, high blood pressure, etc., and that they can be modified to include brain health messaging. So for example, visit your doctor regularly, work with him or her to actively manage your diabetes to help your brain stay healthy. By weaving in brain health information to current chronic disease prevention or management messaging, really falls under the educate and empower from the HBI 25 action items. Next slide, please. Oh, and on this slide with the fans, the front it says one thing, and then the back says let's talk about it, and it gives some of the messaging, and then contacts both for the Center for Multicultural Health, where people can reach out for services, as well as our state Alzheimer's Association. So the next slide talks about our contact information, and please really feel free to reach out to Janna and I if you have questions, and if we can share any of our resources and materials so that you don't have to recreate the wheel. Thank you so much. I'm going to turn it back over to John.
Thank you. Thank you so much, Janna and Marci. I've heard parts of this presentation before, and I think it's just such a wonderfully innovative approach. And for everyone that's listening on today's presentation, I hope their process, some of the things that they've learned, has really helped spark some ideas about how your own agency might be able to adopt a similar approach. I just want to remind everyone, all of our participants today, to please use the Q&A feature to ask a question. Make sure you find that Q&A icon either on the right-hand side or at the top of your screen. We'll have a Q&A portion at the end of today's presentation. But I'm now pleased to introduce our next speaker, who will be highlighting some new data analysis that can illuminate the life course approach to Alzheimer's, the intersection between subjective cognitive decline and chronic conditions. Our next speaker is Dr. Christopher Taylor. He's an epidemiologist with the Centers for Disease Control and Prevention, Alzheimer's Disease and Healthy Aging Program. The Alzheimer's Disease and Healthy Aging Program is which houses the congressionally appropriated Healthy Brain Initiative. Dr. Taylor earned his PhD in epidemiology from the University of Pittsburgh Graduate School of Public Health, where he worked on several longitudinal studies of older adult health. He came to CDC in 2010 as a postdoctoral fellow in the Epidemic Intelligence Service. And in addition to dementia and caregiver issues related to older adult health, his research interests include traumatic brain injury and infectious disease-related mortality. Dr. Taylor.
Thank you very much, John. Welcome, everybody. Thank you for joining us all this afternoon. So I'll move right into the next slide, please. So what is dementia? So dementia is changes in the brain resulting in loss of cognitive function that can interfere with daily life. Dementia is an umbrella term that includes many forms, including Alzheimer's disease, but also vascular dementia, Parkinson's disease dementia, and among others that are included on this slide. And Alzheimer's disease is believed to be the most common form of dementia, but many or the majority of cases of dementia have multiple causes. Next slide. However, Alzheimer's disease or other forms of dementia are not easy to study in a traditional public health context. Self-report surveys are not reliable in those with dementia because advanced memory problems and other issues with reasoning and decision-making. Instead, we focus our research on subjective cognitive decline, or what I'll refer to as SCD. SCD is the self-reported experience of worsening or more frequent symptoms of confusion or memory loss. and it's one of the earliest signs of Alzheimer's disease or other related dementias. Not everyone with SCD will go on to develop Alzheimer's disease or related dementia, but many do. And some studies have shown that about half of adults 65 years of age and older with SCD will develop some form of more severe cognitive decline within 7 to 18 years, depending on the study you're looking at. Regardless of the progression, memory problems or confusion can disrupt a person's ability to live independently, especially in a way that allows them to avoid risks to their future health. Next slide. So for this analysis, we examined the relationship between SCD and chronic conditions. We already know that the prevalence of both SCD and chronic conditions increases with age. And older adults older than 65 are more likely to report SCD compared to adults aged 45 to 64. They are also more likely to report multiple chronic conditions compared to adults 50 to 64. Previous studies have also shown associations between cognitive impairment and severe chronic conditions, including heart disease and stroke, diabetes, and chronic kidney disease. We know there's a relationship with these chronic conditions. We also know that some chronic conditions, if poorly managed, can lead to further cognitive impairment. Additionally, we know that multiple chronic conditions and patients on multiple medication regimens have increased risks for things like drug-drug interactions that can cause memory problems or increase confusion. Next slide. And next slide. So the data were drawn that we used from 3 years of survey data from the Behavioral Risk Factor Surveillance System, or BRFSS. This is a national telephone survey administered by all 50 states and DC, in addition to some territories. This survey is administered every year. It's coordinated by the states with technical assistance from CDC. So from 2015 through 2017, the optional 6-question cognitive decline module that we sponsor as part of our program here at CDC was administered once to at least 49 states, DC, and Puerto Rico. The cognitive decline module is only administered to adults 45 years of age and older. So respondents who answered yes to our screening question, and our screening question is, during the past 12 months, have you experienced confusion or memory loss that is happening more often or is getting worse? Those that responded yes to that were categorized as having SCD and were asked additional questions within the 6-question module. Just a note, because this comes up frequently, the BRFSS interviewers are trained to end an interview if they believe a person is providing poor quality interview data. So just because a person reports SCD symptoms does not mean that their BRFSS responses are invalid. The SCD question is a subjective question and does not necessarily indicate poor functioning on an objective scale. So SCD means that a respondent reports their memory is worsening, not that their memory is objectively poor. So I like to point that out when I give talks like this. Next slide. So as part of BRFSS, all respondents were also asked about their medical history for 8 chronic conditions. And these included asthma, heart disease, stroke, non-skin cancer, chronic obstructive pulmonary disease, or COPD, arthritis, kidney disease, and diabetes. Next slide. And next slide. So in terms of results, overall, 1 in 9 adults 45 years of age and older, or 11.1%, reported SCD, those symptoms of worsening or more frequent confusion or memory loss. The prevalence in adults 45 to 64 years of age was 10.8% compared to 11.7% in adults 65 years of age and older. Next slide. We also saw that more than 75% of adults 45 years and older with SCD also have at least one chronic condition compared to less than half without SCD. So for adults 45 to 64, less than half of those without SCD have a chronic condition, but you can see that the prevalence is higher in adults 65 and older. Next slide. And next slide. So adults identifying as non-Hispanic, Black, American Indian, or Alaska Native, or with other or multiple races had significantly higher prevalence of SCD compared to non-Hispanic white adults. The red oval on your screen shows the percentage of those in each race category that had SCD and chronic conditions. And you can see those percentages are pretty high. Those that had at least one chronic condition average around 80% of those with SCD and with a chronic condition. Next slide. So this table shows that regardless of age, adults with SCD had a higher prevalence of chronic conditions compared to those without SCD. And I wanted to note, it's highlighted on the slide there that all of these values are statistically significant. Those with SCD do have higher prevalence of chronic condition. Next slide. And that was in adults 45 to 64. This is the same finding in adults 65 years of age and older. So for all 8 of the chronic conditions that we examined, the prevalence was significantly higher in those with SCD compared to those without SCD. Next slide. So looking at it in a different way, in adults 45 to 64 years of age with chronic conditions, the odds for SCD is increased for all of our conditions examined. Also, the odds for SCD increases with the number of chronic conditions reported. So if you look in the bottom 2 rows of this table, the odds of having a condition in those with SCD is 2.3 for those with one chronic condition, and for those with 3 or more chronic conditions, the odds of SCD is 4.8. You can see that there's sort of a dose response that's suggested by some of these results. Next slide. So these data for adults 65 years of age and older also show the same thing as the previous slide, which was adults 45 to 64, but the odds ratios are smaller. However, they are all still statistically significant. Next slide. And so one of the questions asked as part of our module is if those respondents with SCD have talked to a healthcare provider about these symptoms. And what we found was adults with at least one chronic condition were more likely to report their symptoms of SCD to a healthcare professional than those without chronic conditions. And this finding is true regardless of age. Next slide. I'm going to discuss our conclusions. Next slide. So we found that comorbid chronic conditions were a significant burden in persons with SCD. And we also saw that an increased prevalence of some chronic conditions were found in those with SCD that was at least 50% higher in those with SCD versus those without. In fact, there was a 2 to 3 times the prevalence of some chronic conditions in those with SCD compared to those without SCD. We know that this is a real burden in adults with SCD. The data also showed that some differences in race and ethnicity are important to note when examining this relationship. We know there are differences regardless. Some of our previous work looking at race and ethnicity in some basic papers also showed there's some race differences, but it's also compounded when also talking about chronic conditions. Next slide. So chronic conditions can often require some form of medical management. And that medical management can include taking medications as prescribed, scheduling and attending appointments with healthcare providers, maybe managing diet, getting regular physical exercise, or tracking their symptoms. So successful management, we know, this is the basis of public health, can prevent or delay progression, disability, and hospitalizations as a result of chronic diseases. The management of chronic conditions, though, can be made more complex with each additional condition, as that may mean additional medications, appointments, and or testing. So memory loss or confusion can impact chronic disease management, and that's already evidenced in persons with advanced cognitive decline, such as Alzheimer's disease, because we know that impacts executive function. Next slide. it is possible that the presence of or the treatment for chronic conditions might cause STD to be concealed. For example, memory loss might be assumed to be caused by a condition or treatment that a person is taking or experiencing. If the medication they're on might have a side effect on their label, the symptom might not be reported by the patient. Or if the symptom is reported, the cause might not be further investigated by a healthcare professional. So if a patient is in the beginning stages of Alzheimer's disease or related dementia, rather than what might be presumed to be a side effect, for example, then the opportunity for early stage intervention might be missed. So this is something we really need to think about when we're talking about managing chronic conditions in adults, especially as it relates to memory problems. Next slide. We also know that untreated chronic conditions can cause symptoms of SCD, for example, hypothyroidism. As well, treatment of chronic conditions can have side effects that affect memory, and this is true of several classes of medication, including statins for cholesterol management, opioids prescribed for pain relief, antidepressants can affect memory, sleep aids, some classes of incontinence drugs, and beta blockers that are commonly used to treat hypertension. That's something also we have to think about as when you're thinking about someone who has to manage their chronic conditions. Also, drug-drug interactions can also cause side effects, and so it's important, to really make sure to seek medical advice when there is memory loss or confusion. And this is really a message we're trying to get out there, is that memory loss isn't always Alzheimer's disease, and even if it is, it's so important to go see a provider, especially in the early stages. So you can talk about what might be causing this, if your symptoms can be lessened, if you can receive some form of treatment. Next slide. So this further suggests the importance of regular medical contact with providers and the importance of initiating discussions about memory loss in older adults. Adults are more likely to discuss their symptoms of SCD if they're already diagnosed with a chronic condition. We see that in these data. Patients may be concerned that memory problems are a manifestation of their chronic conditions, perhaps. It's also could be that they're already in contact with a trusted healthcare provider that's helping them manage their existing chronic condition or condition. And it further suggests the importance of regular medical contact with a healthcare provider. Next slide. And so this final slide, I talk about possible implications for state public health. So chronic conditions and STD can be intertwined, and this can complicate things like treatment regimens, diagnostic efforts, and may increase healthcare costs because it may take several visits or maybe to see specialists or for additional testing to really get to the root of what might be going on when someone has symptoms of memory loss. We also know that race and ethnicity may be related to risks for both STD and chronic diseases, and prevention efforts may have to be tailored to ensure that they are culturally appropriate and focused to ensure that persons of all backgrounds and cultures understand the symptoms of cognitive decline, especially those that have existing chronic conditions. And finally, state-specific increases in chronic disease prevalence might also result in a co-occurring increase in cognitive decline for a variety of reasons. Also, the converse might be true. A decrease in one could mean a decrease in the other. And so this is important to think about when you're talking about planning for programs at the state and local public health level. Now, the next slide is my last slide, just to say thank you. And I look forward to hearing if any of you have any questions.
Great. Thank you so much, Dr. Taylor. And actually, just one quick question before you put yourself back on mute. Has the study on the odds ratio data, is that published? Is that coming? Can you give our listeners just a quick insight about that?
Yes, thank you. Yes, the study has been accepted and will be out in the Innovation of Aging next year. And so if you you're interested, if you go to our website, cdc.gov/aging, and sign up for our newsletter, when that article is released, we will include that notification in the newsletter.
Excellent, excellent. So everyone who's listening to today's webinar, you're getting a sneak peek of that great data to come next year. Thank you so much, Dr. Taylor, for that presentation. Again, I've heard parts of that presentation before, but each time I listen to it, I learned something new. And just a quick reflection on that data in connection with our presentation today. Just the data, I think, really shows that like what a big, how big of a burden chronic conditions can be on people who are experiencing cognitive issues. And so when we think about that from the life course perspective, when we think about that from the whole agency perspective, especially since a large portion of these individuals are not that older adult population. These are our working adults, 45 to 64. It really allows us as public health professionals an opportunity to intervene, think about the cognitive concerns, and how we might be able to address those in our existing portfolios. So thank you so much, Dr. Taylor, for that presentation. As a reminder for everyone on the phone, we'll begin our Q&A session in just a few minutes. Please do use that Q&A feature to the side of your screen or at the top, and we'll take some questions in just a few minutes. But before we switch over to the Q&A, I do want to introduce our next set of speakers who are going to provide some context for the presentation that we've heard today from ASTO, the Association of State and Territorial Health Officials. We'll hear from Talyah Sands, the Director of Health Improvement at ASTO. She provides capacity building assistance to state and territorial health agencies related to heart disease and stroke prevention, healthy aging, and healthy people. Previously, Talyah supported ASTO's tobacco control and diabetes portfolio. Talyah earned her Master of Public Health degree at the University of Michigan with a concentration in health behavior and health education. We'll also hear from Kelsey Donnellan. She is emerging. They are an emerging professional in public health with a focus on brain health. They serve as Senior Analyst of Health Improvement at the Association of State and Territorial Health Officials, where they provide capacity building and technical assistance to implement the Healthy Brain Initiative Roadmap. Kelsey's education is in interdisciplinary studies, and their professional background is in food systems, HIV policy, and tribal health. Kelsey and Talyah, please take it away.
Thanks so much, John. Hi, everyone. This is Talyah Sands at ASTO, and I just want to thank the speakers so much for your insights, and it's been a pleasure to learn from all of you. We are so impressed by Washington State's leadership in brain health and healthy aging, and think that the method that they've taken can really be applied across multiple departments. And so a few of our kind of takeaways from that approach is taking the next step in a few different ways, starting by looking within. I think the Washington model is a clear, simple, easy way to understand where public health actions or activities fit within the roadmap for the Healthy Brain Initiative. I think people really appreciate that simplicity and breaking it down and making it easy to understand. And so by engaging a health agency through that process of doing an assessment, it helps to break it down and also gets healthy aging and brain health on the radar of staff from across the agency, which is very intentional, and it is inspiring to see that breaking down of the silos. There also is a need for a cultural shift, kind of getting beyond focusing on a certain population group or age group rather, and thinking of that life course perspective. I think the assessment here does a really great job of that. And so kind of within that, there's this need to develop champions to help carry that message and cultivate buy-in and understanding of everyone's role in healthy aging and brain health across the agency. And this can be supported by leadership, which is really important. And I think the Washington State team did a great job of demonstrating some different ways to do that through the development of an executive summary and really having some clear goals and frameworks that were really, I think, easy to get, an easy sell for those that they shared it with. And I think as well, there's a strong commitment to the time and energy that this takes to foster those relationships. And so thinking about investing in that in order to support, I think, the strong approach in addressing the Healthy Brain Initiative Roadmap Action P3 of educating decision makers on the need and benefit of all public health addressing healthy aging and brain health. And so I am going to pause there and ask my colleague Kelsey to chime in with anything that I may have missed and share a couple other things with you.
Thank you, Talyah. This is Kelsey with ASTO. I think you did a great job covering some of the ways that state and territorial health officials and their staff can take the next step. I agree with the culture shift being a primary part of this change, and ask that, John, if you could go to the next slide. We have some resources available for you to access for your public health agency. On the left, you see screenshots of our materials made by and for Indian country. These were developed in partnership with the International Association for Indigenous Aging, and they're ready-to-use materials. Here on the slide, you see expert excerpts from our provider guide, which provides detailed information about certain chronic diseases, along with messaging that might be helpful for American Indian and Alaska Native people. It also includes posters, flyers, news articles, radio PSAs, both 30 seconds and 60 seconds, and videos including real families and their stories. These are suggested to be played in health clinics or at health fairs. You can access all of them through our website at asto.org/healthy-aging. And on the right side, you'll see resources for public health agencies broadly. We ask you to consider these as you inform yourself, your colleagues, and your leadership. In the back top left, you see the ASTO Connects. Last year, we ran a series on brain health, including 3 different series that covered a variety of topics that might help launch your conversation and get you into that culture shift and sort of the assessment prep that's necessary. On the right middle, you'll see a issue brief about some of the policy changes and partnerships relevant to caregiving and those caregiving for people with dementia. And finally, I'll end with the the video you see at the front. It's When Brain Health Meets Public Health. It's a 3-minute sketch video. We highly recommend using it for that partner engagement and leadership buy-in. A key message there is by the time you finish watching the video, another person will be diagnosed with dementia. With that, I'll turn it back over to you, John.
Great. Thank you so much, Talyah and Kelsey. And thank you again to all of our speakers today. As we move into our Q&A portion, I just want to remind everyone about that life course approach that we discussed right at the beginning and how there are multiple opportunities for intervention across the lifespan. As you begin thinking about this and about how brain health, Alzheimer's, how caregiving issues may fit into your own portfolio, please be sure to find additional resources online. We just heard from ASTO about their wonderful resources, but please do check out alz.org/public health, as well as cdc.gov/aging. All three sites have wonderful resources, primers, background data, to really help you get started, take the next step, and begin integrating some of this brain health, some of this Alzheimer's and caregiving work into your own portfolio. And now it's time for our question and answer session. And I'm going to kick it off with a question for Washington State, for Marci and Janna. And just an introductory question for an agency, if an agency is considering taking this approach, a similar approach to you did, what would you say is the most important first step for someone who would like to take a similar undertaking?
Janna and I were just consulting to see what we agreed to. We would say that, this is Marci, that we would say that it's really important to start with making the case. And I know the slides were hard to sometimes follow because of the way they were going slowly, but if you want to email us, we can share with you our Make the Case document. It would probably be a slightly different for you because it's got some of our state data, but there's also other things that you could take from that. So I think it's making the case and definitely having leadership. We didn't say this, but our state health officer, Dr. Kathy Lofi, and John Weisman, both have been really supportive of this work. And he's our Secretary of Health, and he's been very supportive of this work. And then I know you asked for only one thing, but I think you need the champions, you need the leadership buy-in to make the case, and then you need some funding to support the people that are leading the work, like Janna and I. You need some staffing. So those would be our, anything else, Janna?
You covered it. Thank you.
Thanks for the great question.
Excellent, excellent. And wonderful advice to get started. There are definitely opportunities for public health agencies around the country to begin thinking about those three things: finding a champion, talking to leadership, and potentially dedicating some staffing time to this issue in order to see a similar level of success. And one other quick question for Washington State. Was there any kind of pushback or any kinds of roadblocks that you think would be helpful for others who are considering the same approach?
One of the sort of hiccups that we experienced, and Marci touched on it a little bit in her part of the presentation, was that when we convened our work group of 31 people, we had some folks who had already figured out how to integrate an aging perspective into their work, and we're also already addressing dementia. So programs like the Stroke Awareness Program, for example, was already deep into this work. Our Adult Falls Program, Falls Prevention Program, was also already deep into this work. And so I think it was a little bit hard for them. They were ready to really run down the road and do some things that were beyond the assessment we needed to do. But we had great conversations about how we needed to level set, get everybody really comfortable with both life course theory and the Healthy Brain Initiative, and really spend this time this year looking for the opportunities, which to them seemed pretty simple. But I think through the conversation, we all realized that it was important to get a larger number of staff really comfortable with and thinking about how to address aging and dementia in their work than to run forward with just a few staff. Marci, do you cover it? Do you think?
Yeah, I think you covered it. The only other thing I would say is that you really want those people who are deeply knowledgeable and are very excited to move things forward. You want them to still stay engaged while you figure out your assessment. And so I think it, like Janna said, it's through conversation.
Wonderful, wonderful. I always find those kinds of lessons learned, those best practices, stories from the field, those kinds of tips and tidbits, insider knowledge are always really helpful and go a long way in the public health sphere. Thank you for sharing that. Dr. Taylor, two quick questions for you. Has there been any analysis of this chronic condition or SCD data in supportive housing?
Not that I know of. So from BRFSS, our data, it's a landline and cell phone survey, and it's pulled from community living adults, depending on if that's considered community living or not. But we don't have there's no variable in BRFSS that defines if it's supportive housing. So we don't have any. If we have data on a person in that situation, we don't know who they are.
Gotcha. Thank you for that clarification. And Dr. Taylor, if you could just I know you talked on it or touched on it during your presentation, but can you repeat for us why the SCD data, since it is self-reported, is a good and reliable measure for the examination that you did?
Sure. Yeah, because the question that we ask is, during the past 12 months, have you experienced confusion or memory loss that is happening more often or is getting worse? So the question is subjective sort of in two parts. One, it's subjective because it's self-report, so it's what the person feels. But it's also subjective because it's asking, during this past 12 months, is what you're experiencing now worse or more frequent than it was before. And we don't know what a person's level was, maybe 6 months ago. So if someone says, yes, it's worse, it could be because they've gone from functioning at a 10 out of 10 to a 9 out of 10 or an 8 out of 10. And so we don't necessarily believe, we don't have reason to believe that there is a reason to suspect that the person we're talking to has, severe cognitive decline. And also, the other sort of thing to know is the BRFSS has been conducted since 1984. And completes more than 400,000 interviews every year. So the interviewers are highly trained to, really read a respondent and know to end an interview if they think a person is providing poor quality interview data. And so we have strong confidence in the reliability of the data. This is our SCD question module is just one additional data point that we can have to help us know about this very early stage of memory loss, which, as we know, just because someone has memory problems, it could be episodic. It doesn't necessarily mean that they are demented or will go on to develop, something like Alzheimer's dementia.
Wonderful, wonderful. I think that clarification is always important to keep in mind when we are talking about a self-reported nature, particularly of cognitive issues. And so that reliability, that long-term collection, I think is important to keep in mind. And I know we are a little bit over the hour today. We will be sending out a link with a feedback form requesting feedback on today's presentation. In order to serve you better and continue providing quality content, please consider taking 2 to 3 minutes to fill out that feedback form. And just as a summary for takeaways from today, what we heard, we know that public health can intervene at any age to reduce the risk of cognitive decline and help improve the outcomes for people affected by Alzheimer's and other dementias. Individual departments within public health agencies can address healthy aging and can align their portfolios to meet the needs of brain health concerns and caregivers. Chronic conditions and cognitive issues frequently intersect, and existing strategies that work for one can address both problems. And finally, the Healthy Brain Initiative Roadmap can help guide public health agencies toward meaningful policy, systems, and environmental changes. Thank you very much for joining us today. For more information, please visit the links that you see on your screen. Thank you again. Take care.